Good evening, everybody. This is Dr. Mukesh Kumar Shah and Dr. Gautam Jha with a presentation on cerebrovascular accident, part 3, and we'll describe general management and TIA. The first part, general management. The goal in the initial phase include ensuring medical stability with particular attention to airway, breathing, and circulation. So initial management is always limited to the airway, breathing, circulation, but there are lots of things to do in a patient of stroke. At emergency, we must quickly reversing any condition that are contributing to the patient's problem. So those are related to deteriorating condition that are related to the deteriorating patient condition should be reassessed properly. And another is the determining if the patients with acute ischemic stroke are uh, candidates for the intravenous thrombolytic therapy or intravascular thrombectomy. Is there possibility of that treatment or not? If it is done earlier, then the patient's morbidity can be reduced. So nowadays, we must keep attention regarding thrombolytic therapy and endovascular thrombectomy. Another important point is that determining the pathophysiological basis of stroke. This will help what is the reason behind the stroke. So it will reduce the recurrence also in future. So we must concentrate, find out the pathology behind the stroke. We always, in any patient at emergency room, we must always look at the air is intact or not, breathing is appropriate or not, and there is circulation is maintaining or not. Stroke and patient presents with the trauma. So airway, breathing, circulation, disability, and exposure are important. But among these 5, we cannot forget airway, breathing, and circulation. So management of hypoxic condition. Any patient of stroke may present with the decreased saturation level. So we must look that either patient is uh, conscious, so that is evaluated with the GCS, Glasgow Coma scale. If it is not altered, it is 15 by 15, then we must look for the saturation. And if it is 94 or above, we must consider it as normal. But if it is less than 94, at that time, less than 94, at that time, oxygen support is needed, and which can be given with the nasal prong or face mask. Another thing we must think that if the GCS is altered, if it is less than 15 by 15, then what we have to think regarding hypoxic management. So once again, we will look for saturation. If it is 94 or above, it is normal. If it is less than 94, there oxygen support or supplementation is needed, and which can be given with the help of the nasal prong, face mask, whatever we do. But if the patient needs intubation, we think that the patient may need intubation. First, we have to try with the high flow oxygen, which can be given by the high flow nasal prong or face mask. And most of the patient requires high fraction of inspired air, which can be given with a different method, and patient may get improved. So intubation is not a earlier management. It should be reserved at the later stage, reserved for the later stage. If we could not manage with the high flow oxygen, then only we jump to the intubation. So intubation should not be our prior, but it should be reserved step for hypoxic management of the stroke patient. Other measures, we can use the laryngeal mask airway, intubation and bag and mask ventilation, intubation and mechanical ventilation, whatever the facility we have. And at the remote area, we can use the LMA also for initially, and then we can prepare, we can buy the time at that for the intubation, and we can prepare all things for intubation at that time. And after that, uh, after that we can go for the intubation. Management of hypovolemia and dehydration. Now, in ischemic stroke, hypovolemia is mainly due to the depletion of the volume of the fluid, and particularly in acute stroke and in old age person, there may be the hypovolemia. So it should be treated, but if during the evaluation of the hypovolemic state, it should be individualized. It should not be generalized, and it is based on electrolytes and cardiovascular status of the patient. So using uh, isotonic saline is the basic uh, way of management of hypovolemic dehydration. But we must remember that what we should not keep, one is the glucose containing fluids or hypotonic fluids. It may be half isotonic or 1/5 isotonic. It should not be given to the patient with the ischemic stroke. In hemorrhagic stroke, in hypertonic, saline is useful because the edema is decreased with the hypertonic saline. If we give in the hemorrhagic stroke patient, the edema that presents in the brain is reduced. So we generally use the hypertonic saline. After that, another important thing in the patient of stroke is the sugar level management. We must remember the figure 80 and 179. This is the normal range of the sugar level for the stroke patient. So target blood glucose level is 80 milligram per deciliter to 179 milligram per deciliter. So what we can find out that the blood sugar level should be in this range, and it should not exceed 180, and it should not be less than 60. The uh, hypoglycemia can cause the focal neurological deficit, and it can mimic with the stroke, and severe hypoglycemia can cause the neurological injury. Check and correct blood sugar. We must check and correct blood sugar. If the blood sugar is less than 60 milligram per deciliter, which is equivalent to 3.3 millimole per liter, and this should be our first opportunity. Hyperglycemia. Patient with the blood sugar level more than 126 milligram per deciliter is considered as hyperglycemic. But we think that the normal range is 80 to 179. So that if the blood sugar is less than 180, it should be accepted. But if it is more than 180, we must treat. But for the definition, 126 is considered as the borderline. Why hyperglycemia is danger? Because it augments the brain injury. How? It increases the tissue acidosis from anaerobic mechanism and free radical generation, and increasing the blood-brain barrier permeability. These are the basis for the augmenting the brain injury in case of hyperglycemic patient with stroke. So hyperglycemia should be treated. Fever management. Fever may contribute to the brain injury in the patients with an acute stroke. Hyperthermia may act by the several mechanisms to worsen the cerebral ischemia. What are those mechanisms then? The mechanism is the enhance the release of the neurotransmitters, exaggerated oxygen radical production, more extensive blood-brain barrier breakdown, an increased number of the potential damaging ischemic depolarization in the focal ischemia membrane, and impaired recovery of the energy metabolism, and enhanced inhibition of the protein kinase. Another last one is the worsening of the cytoskeletal proteolysis. So among these, we must remember that there is a release of the neurotransmitter, and which is enhanced in fever, so it may damage the brain tissues. So exaggeration of the oxygen radical production. This is another mechanism. So this, and another is the more extensive blood-brain barrier breakdown. These three things are the most responsible for the brain damage. We should not forget these 3 points. So that fever should be reduced with use of antipyretics in case of acute stroke. Another important point in the management of acute stroke is position of the patient. Out of that, the head position is the very important, very useful, because it prevents the elevated intracranial pressure. So if the intracranial pressure is raised, we can find out clinically also. So at that time, the head should be raised, and it reduces the edema of the brain also. So in initial 24 hours, it is very important to elevate the brain of the patient, head of the patient. That will reduce the brain edema. Another, elevating the head is also important because there is the less chance of aspiration. If the patient is unconscious or there is dysphagia or diminished consciousness, at that time patient may aspirate, but by elevating head, the aspiration, chance of aspiration decreases. Third one is the cardiopulmonary decompensation or oxygen desaturation uh, is maintained if the head position is elevated. So maintaining head position is very important in case of the stroke patient. So at our ER also, we should practice this one. Swallowing assessment is another important step of management, because I have seen a patient in emergency where a patient is fed with the liquid, that is the dal in our common language, and the patient get aspirated, and finally he was intubated. On the same night, patient died. This is the real scenario I have faced few days ago. Patient was referred, but he died at the Star Hospital. So so swallowing is the very important. I want to focus here. The swallowing, we must assess the patient state. Patient can swallow or not. So dysphagia is common after stroke. Major risk factor for aspiration, pneumonia. Assess prior to oral medication or feeding. This point should be remembered. So how will assess? The assessment by the sips of water. We give the few drops, sips of the water. If he can swallow, then we can promote feeding process. And presence of gag reflexes also reflects that patient can swallow. So these two things we must practice, because we can save the life of the patient who presents with the stroke. Keep patient NPO if the patient cannot swallow. This is the another important point. Okay. Management of the blood pressure in the patients with the ischemic stroke. So we always get confused that what should be the blood pressure of the patient when a patient comes with the hemorrhagic stroke or ischemic stroke. So I want to discuss this point. Blood pressure in case of ischemic stroke should be maintained within the range. Systolic blood pressure should be less than 220 millimeter of mercury, and diastolic should be less than 120 millimeter of mercury. And our concept is that it should be managed with the 120 by 80. So we have to change our concept from now onwards, that systolic blood pressure should be kept at somewhat higher but should not be more than 220. Similarly, diastolic blood pressure also be higher at the 120 but should not be more than 120. So if the blood pressure is more than 220 by 120 millimeter of mercury, we have to give short acting intravenous medication to reduce the blood pressure to a target blood pressure. What are the target? Our target is this one, 220 to 120. It should be done in the initial 6 hours. So we must keep in mind that in ischemic stroke patient, the systolic blood pressure should be less than 220 and diastolic should be 120. So management is only required if the blood pressure is higher. Management of the blood pressure in the patient requiring thrombolysis. If the patient is ischemic stroke and he presented earlier, that means earlier to 4.5 hours, 4.5 hours. So, and we are planning to give the thrombolytic agents. At that time, the blood pressure should be maintained at the systolic blood pressure should be 185 millimeter of mercury and diastolic should be less than 110 millimeter of mercury. If we are planning for thrombolysis and the blood pressure is higher than 185 to 110 millimeter of mercury, give short-acting intravenous medication, IV infusion to reduce blood pressure to a target blood pressure. It should be done in initial 24 hours. Management of the blood pressure in a patient with the hemorrhagic stroke. This is the another concept for the hemorrhagic stroke, where the blood pressure should be lowered. But how? I will explain. If the systolic blood pressure is more than 200 millimeter of mercury or MAP is more than 150, then consider aggressive reduction of blood pressure with continuous intravenous infusion with the frequent blood pressure monitoring every 5 minutes. If the blood pressure is 180 millimeter of mercury or MAP is 130 millimeter with the possibility of raised ICP. I want to focus this point, with the possibility of raised ICP. Then consider monitoring ICP and reducing BP using intermittent or continuous IV medication while maintaining a cerebral perfusion pressure more than 60 millimeter of mercury. Another important point, if the SBP is more than 180 millimeter of mercury or MAP is more than 130 millimeter of mercury and there is no evidence, I want to focus here, there is no evidence of elevated ICP, then consider a modest reduction of blood pressure. Example, if the MAP of 110 millimeter of mercury or target BP should be of the 160 by 90 millimeter of mercury, we should not reduce blood pressure drastically. Using intermittent or continuous intravenous medication to control BP or clinically re-examine the patient in every 15 minutes. So another step of management is antithrombotic treatment of acute ischemic stroke and transient ischemic attack. The management of patient with acute ischemic stroke involves the several phases. The goal in the initial phase include the ensuring medical stability. Another is the determining eligibility for thrombolytic therapy and or mechanical thrombectomy. If the patient is presented earlier, that means less than 4.5 hours, 4.5 hours. Another is the determining the pathophysiological basis of stroke, as I have explained earlier also. In addition to reperfusion therapies for acute treatment, there are two major classes of antithrombotic drugs that can be used to prevent recurrent ischemic stroke. One is the antiplatelets, another is the anticoagulants. So commonly used antiplatelet drugs, I want to focus in the antiplatelet drug only because antiplatelet drug are uh, very important, which can save the morbidity, patient from the morbidity. So alteplase and uh, tenecteplase are the most commonly used, but among these two, alteplase are used. For the treatment with the 4.5 hours of stroke onset, alteplase led to a good outcome. For the treatment beyond the 4.5 hours, it decreases the good outcomes. Dose of alteplase is, the alteplase dose is calculated at the 0.9 milligram per kg of actual body weight with a maximum dose of 90 milligram. So maximum dose is 90 milligram and it should be given at the rate of 0.9 milligram per kg. 10% of the dose is given as a intravenous bolus over 1 minute and the remainder is infused over 1 hour. Other measures. Statin therapy. Evidence suggests use for the statin in high dose initially and continuation at the low dose reduce the recurrent stroke and the cardiovascular events in future. So use of statin is also important. So high dose initially and low dose gradually. And SSRI, early use can help in the muscle function recovery. So SSRI can be prescribed to the patient for the better muscle functions because with the elevated mood, they can use their muscles and which leads to the proper function of the uh, muscle and limbs that helps in the recovery. So finally, I want to summarize with this protocol which we have derived. The patient may present with the traditional or non-traditional symptoms at emergency rooms. If the patient is stroke, we must evaluate for the traditional as well as non-traditional symptoms. But at the same time, we must exclude the stroke mimics. So I have already described this. So we must exclude the stroke mimics. And my part is the how stroke is managed in case if there is a ischemic stroke, not a TIA. So workup should be done. Workup should be done. Investigation should be done, and the treatment. Two parts are here, and I will describe now. So what investigation will we should be done? Then CBC, random blood glucose, sodium, potassium, creatinine, lipid profile, prothrombin, APTT, troponin I, and ECG, echo, and carotid Doppler and CT head are investigation that are required. And regarding treatment, if the duration is less than 4.5 hours and hemorrhage is excluded, then at that time we have to calculate NIHS score, and if it is more than 4 or equal to equal to 4, and there is a neurological deficit, at that time we must go for um, thrombolytic agents. If there is duration is more than 4.5, then we have to evaluate the patient, and blood pressure should be kept at the range which I have already described. So if the patient cannot be given the thrombolytic agent, if the thrombolysis could not be done, then the patient can be managed with the antiplatelet drugs and high dose of statins. Similarly, similarly, we have to evaluate the CT also. We have to evaluate CT, and if there is one vascular territory is involved, then we have to rule out either it is small, multiple, or recurring ischemic lesion, or large or cortical lesions. Another is the multiple vascular territory may be involved. So separation, differentiation is very important. If it is the small, multiple, recurring ischemic lesion, then arteriogenic embolism may be the issue. Another, if there is a large or the cortical lesion is involved, then the cardiogenic embolism may be the issue. So at that time, we have to go for the D-dimer uh, evaluation and prolonged ECG monitoring. If the patient has the multiple vascular territory is involved, then at the same time, paraneoplastic coagulopathy may be a possibility. And similarly, vasculitis may be another possibility, and aortic arch embolism may be the another possibility. So if the aortic arch embolism is suspected, then CT angiogram is important. If we suspect the vascularity or the coagulopathy, then at that time we must go for anticoagulant, lupus. It may be lupus, or we must evaluate for the ANA, NCA, protein C, and antithrombin. And if the patient have the multiple vascular territory injury, and if we suspect the paraneoplastic coagulopathy, then tumor scanning should be done. So on the CT, we have to first look for is there one vascular territory or multiple vascular territory. So differentiation in CT is important. Finally, if there is age is less than 50 years, we must evaluate for these tests, ANA, NCA, and protein C, and beta-2 glycoproteins are important for evaluation in case of the patient of the less than 50 years. So with this, I want to conclude that the management of the patient initiates with the airway breathing circulation management. At the same time, blood pressure management is important. Sugar levels should be managed. If the infection and the patient presents with the fever, we must manage for it. Another is the elevation of head is very important. And if the patient is the ischemic stroke and presents within the 4.5 hour, our management should be concentrated for the uh, thrombolytic agent, and it can be initiated in future at our hospital also. Thank you for kindly listening. Now second part will be presented by the Gautam Jha.
Good evening, everyone. I'm going to present on transient ischemic attack. Since TIA was originally defined as a sudden onset of focal neurological symptoms and or sign lasting less than 24 hours and caused by reversible cerebral ischemia. However, this classic time-based definition of TIA was inadequate for several reasons. Nearly about one half of the patient with classical defined TI syndrome have corresponding appropriate ischemic lesion by brain, which is shown by MRI. And what is minor stroke? Minor stroke is defined as the absence of persistent neurological deficit that is potentially disabling. Out of this 7 point, if complete hemianopia, uh, with NIHS score of more or equal to 2, or severe aphasia of more or equal to 2, or visual or sensory extension of more or equal to 1, or any weakness limiting sustained effort against gravity with more or equal to 2, or any deficit that leads to total of NIHS score of more than 5, or inability to walk, or any remaining deficit considered potentially disabling by the patient, family, or the treating practitioner. यो सातवटा पोइन्टमध्ये कुनै एउटा पनि पोजिटिभ छ, एउटा पनि छ भने हामी चाहिँ त्यसलाई चाहिँ माइनर स्ट्रोक हो भनेर कन्फर्म गर्छौँ. And whenever we suspect a TIA as a patient present, it is required for urgent evaluation, since there is high stroke risk associated with TIA as defined by the time-based criteria. And once we suspect TIA, immediate intervention should be done so that we can prevent a significant number of strokes. Risk stratification. Risk stratification should be done, and as this method is reliably is used to assess the risk of stroke after TIA in individual, and it is useful for triaging the patient. And for this purpose, we use ABCD squared score. If age of the patient is more or equal to 60 years, it is given as 1 point. If blood pressure elevation when first assessed after TIA, if systolic blood pressure is more or equal to 140 millimeter of mercury, or diastolic blood pressure, if it is more or equal to 90 millimeter of mercury, it is given as 1 point. If clinical feature, if there is unilateral weakness, it is given as 2 point. If there is isolated speech disturbance, 1 point. And if there is no feature, then we'll give it 0. Similarly, if duration of TIA symptoms, if it is more or equal to 60 minutes, we'll give 2 points. If 10 to 59 minutes, we'll give it 1 point. And if it is less than 10 minutes, then we'll give 0 point. And if the patient is having diabetes, we'll give 1 point. So if the score is between 6 to 7, so there is high chances of that the patient will have stroke in next 48 hours. It's nearly 8%. Similarly, if the score is between 4 to 5, then there is moderate risk that the patient will have stroke in next 48 hours. That is 4%. Similarly, if the score is between 0 to 3, then there is low risk, that is, it is nearly 1% that the patient will have stroke in next 48 hours. Now we'll discuss a case. So a 72 years male presented to emergency with complaint of weakness of right upper and lower limb since last 6 hours. He is hypertensive and BP on presentation was 150 by 80 millimeter of mercury. Patient symptoms increased and became aphasic on standing up, which improved immediately on lying down. The patient was admitted, and after 4 hours of admission, the patient's symptoms resolved. So, you patient ko हामीले हेर्यो भने एज भनेको more than 65 years means will give 1 point. Weakness छ, unilateral weakness छ of both right upper and lower limb, so he'll give 2 point. Right? So to 3 point for patient is hypertensive. So 1 point for that, that is 4, and patient became aphasic. So ABCD square scoring गर्दा यो patient को total score 5 आउँछ. So if score is 5, it means that there is chances of 4% that the patient will have ischemic stroke in next 48 hours. Now this is a picture of showing that and showing the circulation of brain, the distribution of middle cerebral artery. In this picture will show is showing the anterior cerebral circulation, and this and combination of anterior cerebral circulation and posterior posterior circulation. This anterior and middle cerebral circulation, they form a circle called circle of Willis, which supplies most of the portion of the brain. The circle of Willis, it is formed by two anterior cerebral artery, which are these two are anterior cerebral artery, and these two are joined by anterior communicating artery. This is a posterior cerebral artery, and this middle cerebral artery and posterior cerebral artery uh, is joined by posterior communicating artery. These two are the vertebral artery. These two joints to form a basilar artery, which forms the posterior circulation. This is the lateral picture of supplied by middle cerebral artery. As in our case, since the patient is 72 years, he presented with weakness of this weakness of right side with aphasia. So if we see in this, the most probably the lesion could be in this part. This since here is the Broca's area, the patient is aphasic, and the patient has these are the sensory and motor area, and patient has weakness. Most probably this could be lesion चाहिँ यतै कतै हुनु पर्ने हो. If in case यता lesion भएको भए, most probably patient would have visual problems, auditory problems. A patient could have sensory aphasia. In case lesion यहाँ भएको भए, the patient would have global aphasia. Now this third picture, this is a picture showing middle cerebral artery. This is middle cerebral artery, and these are the deep branches. These of middle cerebral artery supplying the internal capsules, corpus stratum. These small arteries are also called lenticular arteries, and in most of the cases, lacunar in fact यहीँबाट हुन्छ. So in the patient we calculated the ABCD square of total 5. So there is त्यो पेशेन्टमा चाहिँ स्ट्रोक हुने चान्सेस चाहिँ in next 48 hours भनेको nearly 4% रहेछ. So regarding the management, as the patient presents with traditional symptoms or non-traditional symptoms. We need to evaluate, and we should exclude the stroke mimics. And once we exclude the stroke mimics, we should evaluate whether the symptoms are stroke static or progressive. If if there is no the symptoms have gone, then most probably this is TIA or minor stroke. So we should do the ABCD squaring. ABCD score. If it is more than 4, we need to admit the patient and investigate and treat accordingly. Else, if the patient is not able to admit, he wants to discharge, then we should investigate and treat. We should admit when the patient admitted or discharged, he should be worked up properly. We should do MRI with MRA. We should do to look for the area of ischemia. Similar, we need to do ECG. 12 lead ECG should be done. So we can look if there is any atrial fibrillation. We can also do Holter if there is any rhythm problem, or for that we need to do Holter. We can do carotid Doppler so that we can see the thickness of if we can see so that we can see if there is any lesion in carotid artery, whether there is any dilation, any stenosis, or any thrombus. Similarly, we can do transesophageal ecography if we are suspecting if there is thrombus, or any embolus is released from heart or from aortic area. Similarly, we need to do CBC to look for thrombocytosis if there is any presence of thrombocytosis. Similarly, we need to look for sodium if the patient had hyponatremia or potassium hypokalemia. Similarly, we need to look for creatinine. Similarly, we need to look for blood glucose, whether the patient is in hypoglycemia or is hyperglycemic. Similarly, we need to look for a lipid profile, and we should treat accordingly. We should treat both the patient who are admitted or discharged with aspirin 75 milligram plus clopidogrel for total duration of 21 days. If MRI shows the evidence of minor stroke, then the dual antiplatelet therapy should be done for 21 days. And these are the references. Thank you.
Uh,
Now,
Thank you
now
for kind listening.